And someone apparently, it sounds like, dropped a room key. And Renee is going to leave it up here on this table here. So check your pockets if you dropped your room key. It may up. Somebody has their hand raised, Renee. Oh, she has the key. I see. All right, we're going to get started this afternoon with the session Non-Technical Skills in the Operating Room. And we're going to continue on from the last session with Dr. Kennedy Metz, who is an assistant professor of psychology at Roanoke College. And she's going to continue to share some of the work she has done in our community with perfusionists and talking about cognitive workload and stress. Dr. Kennedy Metz.
Thank you. Thank you again for the invitation to speak today for a second time. I'm very excited to talk to you all about cognitive workload and stress. This is like my main area of interest. So I will try to get through this in the allotted time without going over, but it is one of my primary interests, so I'm very excited about it. I really don't have any financial disclosures to divulge, but I'll share the relevant one that I mentioned in the beginning of my last talk, that I don't have any clinical training. My PhD was in translational science. My area of focus within that, which is a really broad area, was understanding the impact of cognitive workload and stress on high-performing teams, particularly in healthcare. So just a little bit of background: as a graduate student, that involved bringing residents and fellows from the adjoining hospital into the lab, basically stressing them out and observing what their responses were. And then the later projects involved implementing an intervention, so stressing them out, intervening to see if we could restore their stress levels. As a postdoc and junior faculty member at Harvard Medical School, this involved observing, as I mentioned, hundreds of hours of cardiac surgery procedures and then measuring how stress looked across the entire team in this naturalistic setting. So I have a lot of interest in workload and stress, some experience applying those interests in the operating room, but again, not a clinician. So I'm going to be talking about cognitive workload and stress. We'll first distinguish between those two concepts and then talk about how we can measure and manage them. Starting with cognitive workload. Cognitive workload basically just characterizes the relationship between task demands and the operator's finite and information processing resources. And there are three primary contributions to cognitive workload, which you can see here, these three distinct types of load. There's extraneous load, which is defined as distractions for the operator. So for you in perfusion, this might mean alarms that are going off in the OR, or if someone calls the OR, if someone comes in and asks you about another case during your procedure, things like that, that are external. Intrinsic load is the complexity of the task itself. And then germane load is basically the schema that we've developed from previous processing to assist in the current completion of a task. So this would be basically incorporating, kind of recalling previous information to incorporate it into a new scenario. It's important to note that increasing any three of these buckets, these kind of types of load, will lead to diminished capacity because, again, this is a finite resource. So especially as task difficulty or complexity increases, if we're thinking of intrinsic load, then resources become depleted and cognitive workload could increase to a detrimental point. This can be problematic, again, because it is finite. So if we overload, then bad things may happen. So a quick kind of summary of cognitive workload. I'm going to talk more about stress because this is my biggest interest, and specifically about acute stress. So I think, generally speaking, stress has kind of a negative connotation. Like, no one would choose to stress themselves out if they had the choice. But you can also probably appreciate that it's helpful to have some level of stress to be able to be motivated to get things done. So we can classify acute stress according to two dimensions. There's eustress, which is this good type of stress. The prefix EU is Greek for good. And eustress, just like any type of acute stress, is determined by like basically a two-step appraisal process that we complete kind of automatically. So we first appraise the resources that are internal to us that we feel we have available at our disposal, and then we appraise the demands that are imposed on us by the environment, and we measure those up against each other. If the resources that we have feel like they're sufficient to meet the demands, then we perceive this as a challenge, and our sympathetic nervous system will activate, leading to those familiar feelings of an increased heart rate. That's a primary one, but a bunch of other things I'll talk about in a moment, and through the fight or flight response. So this we can consider to be a balanced model of stress because we're, again, appraising that our resources are sufficient to meet those demands. We experience positive effects, and we're interested and motivated to overcome that challenge in our environment. It could be the case that the resources available to us outweigh the demands that are imposed. In this case, if we are like over-equipped and there isn't enough of a challenge in the environment, then we'll be relatively bored, which won't incentivize us to perform well. But the opposite is also true. If we have too many demands and not enough resources, we experience this state of distress. So again, there's this double layer of appraisals. We're appraising our resources, we're appraising the demands, and if that calculation results in the perception that there are too many demands that we can't meet, then we perceive that situation as being threatening to us, and we are not motivated to overcome it. We become disengaged. In this case, just like with eustress, the sympathetic nervous system is activated, so we experience the same fight or flight response. But in addition to that, we also experience the activation of the hypothalamic pituitary adrenal gland axis, which the end outcome of that is the release of cortisol. So these two processes and outcomes might seem similar. So I'm just gonna share them here side by side to highlight the differences. The primary outcome will be determined based on that initial appraisal and the initial perceptions that we have of our resources and demands. So in both cases, we have adrenaline and noradrenaline are released as a response to the fight or flight activation. But in the case of distress, we also experience a release of cortisol. And that's really the primary distinction, which will go on to influence performance negatively. This little figure here shows the relationship between stress and performance. What you can see on the far left, if we don't have any stress at all, we're probably dead. But if we have very low levels of stress, then we're not interested. We need some level to get us going, but we need enough to get us performing really well. So once stress levels rise enough, then we enter into this optimal range, which would be a map onto the feeling of eustress. And we experience heightened attention and focus, pretty good decision-making skills. All of these procedures are facilitated by a low level or sort of medium level of stress. Bless you. But then if that stress continues to mount, if we kind of experience more like stacking of different stressors, then we could approach this kind of proverbial cliff and fall off into the zone of distress, in which case performance starts to decline again. So something that I want to point out is that where these zones lie and where we fall in this area of eustress, distress, and so on is variable. So within a given person, our perceptions and ultimately the outcome that we experience might change depending on the nature of the task and the types of stressors that we perceive, how big those demands are. But also between individuals, our spot on this curve will vary. So that kind of comes down to the difference in how we perceive our resources, even if the task is the same. So one of my interests is in figuring out where that threshold is, at what point we start to encroach on the area of distress so that we can manage things appropriately and instead stay in the eustress zone and experience the benefits and the increased performance. So this might seem kind of abstract, so I wanted to kind of pose a question. I didn't incorporate a poll because I just didn't plan ahead, but I'm going to ask for maybe a show of hands. Would anyone, this is hypothetical, would anyone be interested in coming up to the stage and verbally counting backwards from 100 by intervals of 7? Anyone think that sounds interesting? We have someone? Oh, no? Anyone think that's the last thing they would rather do right now? So probably more agreement. This, I'm going to try to explain how this exemplifies what I've just talked about. I would enjoy doing this. I like doing mental math. And so I would basically appraise that my resources that are available to me, which would be my ability to do mental math, are sufficient to meet the demands imposed on me by this task. My heart rate would sure increase, but it would actually facilitate my ability to perform on this. I would be sitting in that zone of eustress. Someone, like I guess anyone else in this room, who doesn't think that sounds interesting, maybe you might be appraising that you don't enjoy doing mental math. Maybe on top of that, you would be uncomfortable in front of a room, standing up on a stage. So you might appraise that the resources available to you to do this task are insufficient and that the demands outweigh that. In which case, your heart rate would also be increasing, but you would be releasing cortisol, and that would go on to interfere with your performance in some way. So this is kind of an example of how, if we stack those stressors, things could become too demanding. Even for me, if this was a timed task, if there was a large clock and it was ticking down or something, then I would probably reappraise and I would probably start to feel distressed about doing the same task. So within an individual, between individuals, those things vary. This might seem kind of artificial and silly, but the reason I share this example is because the same processes that are taking place, those same appraisals and the same eventual outcomes are the same when we're doing other tasks that are potentially stressful, including perfusion-related tasks. So one example that I mean, there's probably plenty of examples that you could think of and you could share if you wanted to, but an example of a perfusion task that comes to mind, or an experience that comes to mind that could exemplify this is one time in our OR, there was a training anesthesiologist and the attending was out of the room doing scheduling something. The team was weaning off bypass, and the attendee delivered a bolus of protamine without knowing that should be delivered incrementally. But no one was there to kind of show her. And I guess this was her first case, and she thought she knew what she was doing. So she didn't explicitly talk about or announce that she had done this. It took a while, but eventually, well, not that long, I guess, but folks started realizing there was something going on. The patient parameters weren't what they should have been. So someone finally asked, and she said, yeah, I gave the whole dose. And they were like, oh my God, then everyone freaked out. And the team figured it out. There was no reaction, which is great, but it was still kind of a crisis that was unexpected in the moment. So I mean, in this case, the perfusionist that was on pump was very experienced, had been in that OR with members of that team for probably a decade or so. So he knew kind of what was going on and he was fine navigating the situation. But if it had been someone who is new or less familiar with the team, less familiar with the pump, any of those sorts of things, then those could have represented additional demands that would have kind of stacked and made this distressing. So you can recognize maybe the real outcomes, the real consequences that this could result in. So just sharing this to circle back to that fight or flight response that I mentioned, which again occurs regardless of how we appraise the stress that we're experiencing. This is normal. We our body goes through these changes when we experience anything stressful. These changes are adaptive as well. So if you think, like, if you're hiking and you see a bear on the trail ahead of you, you might feel a little stressed. that's good. It's a good thing because all of these changes are happening to our body as a result of the sympathetic nervous system kicking in. Our eyes will dilate, our pupils dilate to enable us to take in more information about our visual scenes so we can make a better informed decision. And then also our heart will beat faster and harder. Our lungs will inhale more deeply and frequently to deliver oxygen, blood, nutrients to the large muscle groups that will enable us to either fight the bear, like punch it, which is not recommended, or flee. And then things that we don't need to do, like digest food or produce saliva or worry about bowel movements, those are all extra functions that would be taking up energy otherwise. So our body will divert those resources to our muscle groups to help us get away or fight or whatever it is we need to do. So this is normal. This happens to us anytime we experience anything stressful. But if we appraise the situation such that we kind of encroach into that area of distress, the distinction that I mentioned is the release of cortisol, which will go on to flood areas of the brain that have a high amount of cortisol receptors. So the prefrontal cortex, amygdala, and hippocampus are three of those regions. When they become flooded with cortisol, the function that underlies those structures diminishes. So things that the prefrontal cortex helps us with that are really important in most situations, like decision making, attention, and working memory, become diminished. Our ability to retrieve information, our emotional responses, things like that. An example of how attention processes can be disrupted that you can maybe relate to, think about a time where you're really overwhelmed and in this distress zone. Our attention basically narrows like a tunnel, and we kind of have these blinders on, which sometimes could be helpful to hyper focus on something, but usually that rigidity just makes it more difficult to take in other viewpoints or other data points or things like that. So this can be detrimental. And healthcare providers, perfusionists included, present a really interesting use case about this because to perform optimally at your job requires you to do most of these things on a very regular basis. But as Shanna mentioned earlier, and as I think we'll talk about again in the next couple of talks, these are not really systematically trained. So things like managing our stress and other non-technical skills are not incorporated into curriculum, even though they could have a huge impact on clinical performance. So the implications of this, I've already kind of alluded to the idea that if we are overloaded in terms of the amount of cognitive demands that we're facing, if we're overloaded in terms of the amount of acute stress that's mounting, then there's a huge potential that we might commit surgical errors. And to sort of manage that and prevent those sorts of things, there are different ways to measure cognitive workload and acute stress, including things that I talked about in my earlier talk, like subjective measures, but also physiological measures, which all of these things kind of have their place and they're useful in different ways. And there are also different ways to measure both of these. So I'll talk about measuring cognitive workload and measuring stress individually in terms of subjective measures first, and then kind of collectively in terms of physiological measures. In terms of cognitive workload, I alluded to the NASA Task Load Index earlier. This was a questionnaire that was developed in order to measure cognitive workload that's perceived by an operator in any setting, just sort of generally speaking. This is kind of blurry, but there are 6 domains: mental demands, physical demands, temporal demands, performance, effort, and frustration. So folks would indicate how, but there's actually little questions associated with each of them. They would indicate how physically demanding the situation was and so on. So this has been validated for general use, but since the time that this was developed, I think a couple of decades ago, the SURGE TLX, or the Surgical Task Load Index, has been presented as a modified version. The first 3 domains are the same, as you might notice: mental demands, physical demands, temporal demands. But then the last three categories, task complexity, situational stress, and distractions, are substituted in. So they're more specific to the surgical environment and more sensitive to actually measuring the cognitive demands that folks are facing in clinical situations. So this is one validated way, probably the most popular validated way of measuring cognitive workload. When it comes to stress, there are a number of validated ways to measure stress levels. One, for example, looks like this. This is the state trait anxiety inventory developed by Spielberger decades ago. The state trait anxiety inventory comes in two forms. There's a state version, which is how are you feeling in the moment, and a trait version, which is generally speaking, what are your stress levels? So this is what the state version looks like. It's very helpful, it's very valid, all of those things, but it's also quite long. So if you're thinking about collecting this type of data in a clinical setting, it would probably behoove you to think about the amount of time that we're already asking of people. So this is why we in our research have adopted the short form version. There's only 6 statements. It only takes like a minute to complete, as opposed to maybe like 3 minutes. So, but it's equally representative of stress levels. So we're not losing accuracy by shortening the questionnaire in this way. In terms of objective measures, there are tons of different ways to measure workload and stress objectively. And in each of these categories that I'll talk about, there are different ways to calculate the types of parameters, and different ways to calculate them will be reflective of cognitive workload, and other ways will be representative of stress levels. But each of these can represent both categories. In terms of cardiac parameters, the ones that I've already talked about, heart rate and heart rate variability, are the primary measures. Heart rate variability is a huge category that has many different forms, comes in many different forms depending on how it's calculated. Some of those represent cognitive workload more closely, others represent stress more closely. Ocular parameters, there's many different types of ocular measurements or parameters that we could take as well, including pupillometry, blink rate. You could track where people's eyes are moving as they're looking at something. There's actually a lot of work in perfusion with eye tracking that tracks where people's eyes follow on the pump while they're doing simulated tasks, which is a pretty interesting field, I think. Pulmonary parameters, really breaths per minute, maybe the depth of inhalation, those sorts of things. Endocrine parameters, the primary endocrine parameter would be cortisol. And if we can measure cortisol at different time points, which is also more invasive than these other measures, but if we collect cortisol samples at different intervals, then you could actually get a time course to observe at what point did someone dip into that area of distress, if at all. So this would be a good way of measuring the distinction between distress and eustress. Neural parameters, there's many flavors that you could adopt for this too. FNIRS is one that I think is really interesting. You already probably collect NIRS from patients, near infrared spectroscopy. FNIRS is a way to detect functionally the things that are happening in the frontal lobe, primarily. I mean, you can put FNIRS sensors at any location on the scalp to gain information about underlying cortical structures, but a lot of people will place these on the forehead to gauge frontal lobe activity, which would be more directly representative of cognitive workload, for example. There's also EEG, which is pretty non-invasive, but a little more obtrusive. And then behavioral taxonomies. This is not a physiological measure, but you could argue that it's more objective than self-reported measures. There's a lot of different validated behavioral taxonomies that can give us insight into things that are happening at the team level. So you're going to hear a lot more about one of those that is specific to perfusion in a moment, so I won't go into too much detail. But basically, there's ways that observers can be trained to rate behaviors of the team. And these can also, one of the domains in many of these behavioral taxonomies is coping under pressure, which is related to cognitive workload and stress. So the last thing I'll mention are different ways that we could think about actually managing cognitive workload and stress. if we understand them and we have a way of measuring them, that's great, but it doesn't really finish the job. It's helpful to know how to keep ourselves in this area of eustress without crossing over into distress in order to rescue performance or mitigate performance decline. So leveraging cognitive aids is one way of doing this. This came up earlier a little bit, the idea of checklists. The caveat is that checklists are only helpful when they're like done well and intentionally, if there's enough buy-in and so on. Otherwise, it feels like a waste of time and like you're literally just checking off boxes for the sake of checking off boxes. So cognitive aids like checklists can be really powerful, but only if they're designed well and implemented well, I would say. Team training is a really strong way, especially through medical simulation, of helping to instill the skills that will enable people to manage cognitive workload and stress. It's a safe, you can create a safe environment to basically stress people out and help them manage it without any consequences for a real patient, for example. And I'm sure that many of us are familiar with medical simulation, probably been involved with it before. Sterile cockpit has come up a lot so far, at least in the last talk. So the implementing a sterile cockpit when is appropriate to do so could help to minimize distractions. This would help keep extraneous load quite manageable by eliminating or minimizing that component of workload and then keeping us avoiding going into the overload state. Interactive feedback is another way of managing cognitive workload and stress. So there are a few examples of this. Video-based coaching is one of those. Coaching came up earlier as well, and the idea of mentoring. So these can be ways to instill principles that will help other folks to manage their own levels of workload and stress as well. And this is kind of my final thought. There is an I guess, lack maybe or underutilization of the types of training that can help us as clinicians and humans that work on teams in general um, develop and optimize non-technical skills. So I would argue things like cognitive workload and stress, managing those appropriately is a very strong non-technical skill that can help preventable errors, but it's not something that is regularly or systematically included in curriculum. So I'm going to finish early and give my friends some more time back, and then I'm happy to answer questions at the end of the panel and outside of this conference if you have them. Thank you.
We're looking around. Returning to the main stage is our favorite ICBP queen, Shauna.
Hi. Thanks again for having me up here. I am here to talk about non-technical skills in the operating room. And I am excited to talk about this. As you guys know, this is my favorite topic. So we've talked in the past about team steps, and this is going to lead from my past presentation into this one. And so this is more concrete examples of what we were talking about. So we remember the AHRQ came up with the team steps. And so this is a great example of learning how teams are successful. These are the steps that they need, the strategies, the tools, everything they need to improve patient safety, right? They work together, communication, all of that stuff to make teams successful. And so you'll see here, these are kind of the same words we've been using throughout the afternoon, right? Situational monitoring, being aware of the room, learning how to read the room, communication, leadership, mutual support. And the cool thing that you learn when you're in team steps, or if you've taken the course online, which by the way is available on AMSECU if you would like, is that the triangle is the thought process, is that everything, you have to have all sides, you have to have all sides coinciding, and that is how you build your team. So if you have good leadership and communication, they come together and they help you form a great mutual support foundation. If you had good leadership and you have good situational monitoring of your environment, then you have a great process for creating a good communication process. So it all works together. And so that's how this works together. They have a shared mental model that works together. And there's a real awareness with teams that work together like this about what's going on and how they progress through the process. Thank you. Keep going. Okay, never mind. Okay. So this is what we were talking about. So these are team traits, right? So situational monitoring, communication, leadership, mutual support. So the examples of these things would be, being aware. So communication we've talked about is SBAR, closed loop communication, hands-offs, things like that. And leadership is timeouts, like your huddles, your debrief situations, and mutual support is distributing that workload effectively, putting it with the cognitive load environment that is the lowest, or if they have that sterile cockpit environment that is lower, giving them the assignment at the time, or learning how to manage conflict effectively. It's a communication tool, right? It's learning how to communicate when there is a situation and a problem. And so again, these are the kind of teams that back each other up. They correct their errors and they do something about it, because we are going to have errors, but they do something about it. So as we said, they're familiar with their roles, they have positive experiences, and they work together as a team. So how do we follow along with Dr. Kennedy's team, and how do we reduce the cognitive load of the perfusionist? What we want to do is we want to focus on things that we can do to minimize their choices, reduce the necessary steps that they have, and get those things that we were talking about earlier, that shared mental model to reduce that, the options and the choices that they have. If we teach students, coworkers, whatever, to use common patterns and avoid the distractions, limit the interruptions like we were saying, and we use only the words that we need to convey information and develop these routines, this is how we're going to reduce that cognitive load. We're going to reduce the mental effort that it takes to create a task, to complete a task. And so when we do this, we're working on their attention, their memory, their problem-solving skills, and their decision-making skills. And remember, these aren't the skills that we generally have taught in school. So we have to do an active, intentional thought process when we're working with our classmates or our employees. So again, we talked about where our highest cognitive workload is when we do have that high cognitive workload, that's when we have our communication errors. Everybody in here, I'm sure, has been in a situation where something goes wrong and you're stressed out, and that's when you make the communication error. It's a frustrating process, and then you're frustrated, something's going wrong. There's an error with the machine, you're trying to fix it, you can't communicate well, you're stressed out. So you can understand why that triangle exists, right? And so what we want to do is create a script that is also, or a communication tool that fits in those situations as well. We teach closed loop communication. We teach closed loop communication for the regular moments like delivering cardioplegia, but we also need to create those scripts in our minds for these environments when we have other things going on. So just like we talked about, develop a routine, use that closed loop communication in these environments as well. So as we talked about earlier, these are the current evaluated skills that we're used to. This is what we teach in school. This is what you come out of school you're supposed to do. But what we needed in perfusion was a algorithm to help us evaluate our skills. And this is what you can do with your teams once they're graduated, once you've been working. Doesn't matter if they've been working 5 years, 10 years, 20 years, doesn't matter. So all of the specialties here, as you can see, anesthesiologists, scrub techs, surgeons, they all have a set of algorithm. It's an intraoperative non-technical skills associated with their profession, with their society. So what we have done is create PINTS for you. It is perfusionist intraoperative non-technical skills. And don't worry, if you've heard of PINTS, we've talked about it already. We've been doing it before, but I'm going to tell you what we're doing with it and how you can use it in your teams. So just a reminder, a refresher for those of you that might need an intro. This is a tool, again, that you can use to assess the non-technical skills of your teams. And so no, you can see on here, like I wasn't one of the original creators of this project. Some of them are here in the room, but it's kind of been passed down to me and it's kind of a fun project for me. And that's why I'm up here sharing it with you today. And I'm actually using this in my master's program as well. And it is a very great project. And you can see here what you can do with your teams is what they did is they took an expert panel and came up with a list of skills to be evaluated. And I'll show you that list of skills as well. And in this situation, what they did is they had them watch videos, evaluated the videos based on the skills that they were assessing, okay? And then they were able to use this grading scale, which I'll show you as well. But what you can do is take this exact list and evaluate your perfusionist, whether you're talking about a brand new coworker, a new hire, or again, someone who's been working for 20 years. So this is the categories and the elements that they came up with. And it's the same skills that we just talked about, similar to the ones in team steps, but now it's in the PINTS, the perfusionist intraoperative non-technical skills. So these are the skills, again, that we're now teaching in the classrooms, right? Not just how to build a pump, not just how to deliver cardioplegia, but how to communicate, how to make good decisions, and how to have great teamwork skills. So you can see there are 4 categories, and there are 16 elements in which you have to achieve success. So this is what I meant earlier when I said you still get your score, right? You still get your, 82 out of 100, but you also have to succeed at these skills as well. And so again, what we've done is bring these together, and this is how you can use this PINTS intraoperative skills to evaluate your team to make sure that they are communicating well. I do have a couple Slidos in here. I hope they're going to work. We haven't had too much success. If not, there's enough of us, we can just kind of raise our hands. But what we wanted to do was ask you a few questions that a couple of us are going to use in our projects. And I just met a gal today that I think would like to use it as well. So our first question for our group here today is, do you develop a patient-specific management plan for bypass and communicate it to the surgical team before the procedure, such as during the preoperative briefing? So this is an active, conscious plan, not do you stand behind the pump and grunt when it's your turn. Is it working? Okay. Does it just show up or what? Fun, it worked. Okay. All of you do that? Wow, that's impressive. Good, good. We're doing strong work here. Okay, good. So this is what I was talking about. We have a couple more questions. Good. So this is the, what's the word I'm looking for? The grading scale that you can use when you're evaluating your perfusion staff. And so, of course, obviously you hope that your staff isn't in the poor range, but what this does is this leads to fostering a conversation, right? You hope that all your team is in the good range, but maybe what this does is start a conversation. I think it was Dave that mentioned that his team had gotten to a point where some of his staff that had been around for a while had gotten to the point that, they were answering their surgeons, yeah, or, and we all do that, right? Because we get comfortable with our surgeons and we know, but what this does is it starts that conversation that says like, hey, maybe we should get back into the habit of let's everyone use the same communication. So it works, again, for younger, new hires, but it also works for those of us that have been around a while. And so this is how you can use this to improve your team's communication. Here's another one. Do you actively participate in group decision-making with your team members, physicians and nurses, to create a shared mental model, or do you simply follow instructions when given? So again, it kind of goes with that same situation. Like, do you prepare ahead of time? Or do you just go on bypass and then your surgeon just tells you what to do? You know what he's going to say. That's what I would expect a little bit more of. Good. Good. Thanks for letting the Slidos work. That's awesome. Okay, so this is what we're talking about, non-technical skills. This is how you use it. You observe the behaviors, you categorize it using the taxonomy that's already built for you. You start the conversation, teach them how to use it, and you quantify this behavior using the assessment tool. And it gives them a form of a grading system that you can use to improve your communication. Final Slido, I promise. Do you have clinical practice guidelines that outline specific goals for bypass? Example, is your DO2 greater than 280, excuse me, mLs per minute per meter squared? And do you communicate it to the team if these targets are not being met? So 2 parts there. Do you have it? And then do you communicate it if it's not being met? That's going to be helpful for us. Thank you. I appreciate the honesty. So again, this is what we've been talking about the whole time, okay? So we have the skills that we normally come up with. What we want to do now to improve patient care is focus on the teachable skills, right? We're going to talk about communication. Use those 4 categories and those 16 elements. Focus on the communication, focus on the leadership, focus on the situational monitoring and mutual support. And, sometimes you might say, but like, Shauna, isn't this common sense? Like, I've worked with students for 5 years and I no longer take common sense as something everybody has, right? Like, these are skills that we have to learn. We have to consciously think about it. We have to actively bring them into your curriculum or actively bring them into your discussions. Sometimes we don't know what our weaknesses are until you bring them to awareness, right? So you need to focus on these skills to help your team succeed and improve communication. We know still, ever since we've been talking about that error to human whatever report that came out, that was like in the 90s, right? What is it called? Error, right? I'm right. Yeah, I'm right. So that's in the 90s, right? That was like bigger than my hair from yesterday's presentation, right? And that was so many years ago. And we know that still 90% of our patient errors are communication. It's not because the surgeon doesn't know what he's doing. It's not because you don't know what you're doing. It's because of communication. So this is the way that we're going to make this better. And until you're willing to say to your teams and to yourself, we need to work on this, this is gonna help you. So these are the skills that are gonna help you. These are teachable skills. These are things you can focus on and that you can do. You did the hard part by learning to run the pump. Now, this is the uncomfortable part that we all need to get comfortable with. So these are the essentials for your high performance teams, and I know that you can do it. So PINTS, perfusionist, non-perfusionist, intraoperative, non-technical skills will help your perfusionists reduce their cognitive load. Remember, cognitive load is the amount of work that it takes to perform that function. So as Dr. Kennedy Metz's team has proven that we can reduce that likelihood of communication errors, which will reduce our chance of human to machine errors. And that right there is going to improve our patient care. Thank you for your time.
Thank you, Shauna. Our next presenter is Susanna Stripling, and she is a perfusionist at UW Health, where she splits her time between adults and pediatrics. She's also an active member of AMSEC's International Conference Planning Committee and enjoys presenting at AMSEC conferences. The title of her talk is Going on Bypass, Establishing Essential Verbal Communication.
Thank you, Kenny. So my presentation is kind of going to bind what you've heard before. We talked originally, Dr. Kennedy Metz with stress, and Shauna just talked about PINTS. And I'm specifically going to talk about communication and how to kind of use PINTS and use those skills that you've grown to reduce your stress as a perfusionist. So we've kind of already gotten a little introduction to this paper, and I'm, like I said, focusing on that communication portion. This is one quote that I find really valuable that always sticks out for me from that paper. While there may be standardization observed in the use of modern CPB circuit safety devices, significant variation still exists in the conduct and clinical management of CPB support. Such variation may be associated with perfusionist-related errors. So like the previous ladies have said, according to the Joint Commission, approximately 2/3 of medical errors are associated with communication failures. So we're gonna have a fun little scenario on here. So you see two pictures of a perfusionist on here. On the left, you see this perfusionist, and these are the thoughts inside her head. What am I cooling to? What dose of cardioplegia am I giving? Did they want CO2? What kind of cannula should I grab? Whereas you see the other perfusionist that knows exactly the plan. I'm cooling to this. I've got an induction dose of this. I've got CO2 on the field. I've got cannulas picked out. The difference between these two perfusionists, you've got that distressed perfusionist on the left, and their attention is diverted from the task at hand. They're not sitting there thinking, okay, what's going to happen with the patient? Did we make incision? Should I have my lines clamped out and ready to go? Because they're cognitively overloaded. And as Dr. Kennedy Metz said, they're in that mental tunnel. They're just focusing on one thing, and it's their thoughts and their plan, rather than being situationally aware of what's going on in the room. Whereas the other perfusionists on the right, they're prepared, they paid attention, they communicated during that timeout, and they're able to focus on exactly what's going on rather than being confused and being overloaded. One thing that I really appreciate at UW, which I've heard that some other centers do as well, is a preoperative briefing. So all of our surgeons send out an email the night before procedures for non-emergent cases. And in this email, they give a patient synopsis, just a little bit of a history and an indication for that procedure. They talk about anesthesia, lines that are currently in the patient, lines that need to be in the patient, monitoring if we need a blood pressure line in a different arm because of the procedure that we're doing, or even ephemeral blood pressure. There's a perfusion section. What kind of cannulation do they want? What kind of induction for cardioplegia? Are they going to want osteals? Are they just going to want to do an aortic root vent? Like, what's their plan? What are we cooling to? A surgical technologist case, the supplies, the graphs, the steps of the operation, as well as an ICU list. So this email doesn't just go to the perfusionists and the intraoperative team, it also goes to the ICU and the intensivists and the nurses. So they know, hey, this patient is going to have a lot of volume, or this is going to be a long bypass run. This is what we should focus on. This is the products that you should be looking at giving. And then also any relevant articles and images. And I use this preoperative briefing not only to prepare before I walk in the door and have questions ready to go when the surgeon walks in, but I also use it as a guide to follow throughout the procedure to make sure that I'm meeting the expectations and demands of what we're doing in the operating room. Timeout. So this article, The Cognitive Relevance of a Formal Pre-Incision Timeout in Surgery, was actually authored by Dr. Kennedy Metz on the stage. And there's a lot that's important to a timeout. Just like we're talking about checklists, if you're not paying attention and you're not correctly doing the checklist, you're just checking boxes. If you're not listening and speaking up and actively talking during the timeout, then you might as well just not even be in the room. You need to be an active player as a perfusionist because it provides you with situational awareness. What's going on? What do I need to focus on? And then also it shares the mental model. Everybody in the room is understanding exactly your needs to help the patient, and you're also understanding what they need. Hey, this patient has a lot of adhesions. I need you to be quiet during this part of the procedure. Information like that. So the entire team is on the same page. It helps with error prevention because you've got a plan written out in advance, and it's just better because then you can plan ahead and you can focus on exactly what's going on. And also, your timeout should be checklist driven and it should be succinct. There's a lot of information in a timeout. You need to keep the information that you're sharing and the questions that you're sharing driven, and you need to keep it precise so that the surgeon isn't hearing you ramble on and on like I am right now. And then distracting, because then you might ask them a question and they might have forgotten 30 seconds later about what you were concerned about for that bypass run. So at the University of Wisconsin, beyond doing your personal pre-bypass checklist for the pump and doing your pre-initiation checklist, we have this list. It's called the Pause for Pre-Bypass checklist. So after the patient, after they've done sternotomy and they've opened up the chest, lines have been handed up and we're ready to go on bypass, the surgeon says to the circulating nurse in the room, go get the Pause for Pre-Bypass checklist. Everybody stops. All of the music in the room is turned off and everybody pays attention. There are no side conversations, so everybody gets that shared mental model that I've been speaking about. And they ask, are water lines connected? Is the appropriate temperature set? Is your pump primed? Is it free of air? Are your gas lines connected? Is your FiO2 set? Is your gas flow set? Is your ISO ready to go? Is your vacuum tested? What is the ACT? And it's not just a ACT acceptable, yes, no, you're giving a number or you're saying it's still rising. Is the surgeon and the anesthesiologist ready to go on bypass? Because you might be ready to go, but say the anesthesiologist is out of the room or they're adjusting something with the pressures, you want to make sure that everybody's ready to go on bypass because that's a really critical moment in the procedure where you need to focus on what you're doing and that surgeon needs to focus in case anything happens that needs troubleshooting, rather than being focused on something spilling or a drip changing and then all of a sudden you're testing your lines and your pressures are different. This really puts everybody on the same page and I appreciate that about this checklist. Now, maintenance, and I'll keep this short and sweet since we've already covered this a little bit. Closed loop, everybody knows that's what you need to do. Even with students, I think that's a big thing that I teach. They say it, you say it. It's like a bird chirping. Concise. The surgeon, the techs, everyone in the room is super focused on what they're doing. The last thing they need is you rambling on and on about your drainage or something. They need it short and they need a solution. Often surgeons, I've had stressful situations where a surgeon is like, okay, you said the blood pressure is low. What do you want me to do about it? They don't want you to just say something. They want you to say a reason and they want you to say a solution or a question if you have one. So keep it short, keep it focused, and have a goal. Every piece of communication should have, you should have a reason why you're saying it, and you should have something that you want to get out of it. And then also team expectations, especially if you have a lot of different surgeons. So I split my time between two hospitals, a pediatric and adult hospital, and I know my surgeons, and that just makes the procedures go a lot smoother. Because the surgeons are creatures of habit. They want to hear that same script. They want to hear that same piece of information. And if I say to Dr. Smith what I usually say to Dr. Johnson, and Dr. Smith isn't used to hearing, okay, my pressure and flow are good, then all of a sudden he looks up and he's like, what's going on? What's wrong? And you divert their focus away from what they should be doing. So keeping it strict, scripted, and knowing your surgeons and limiting distractions when you're communicating intraoperatively is very important. And if there's something that's bothering you or something that's diverting your focus away from the task at hand, such as music or a conversation in a different part of the room, say something. You're doing your job and it's a team. And if you don't communicate and something happens that puts that patient at risk, then it's on you. It's not on them for having a conversation if you didn't step up and you didn't say, hey, I can't hear what the surgeon is saying. I can't hear what's going on with my pump. I can't hear my alarms because the music is too loud or because you're talking. You need to stand up for yourself. Now, pause for coming off bypass checklist. So this is just one more time to get a shared mental model. Before we come off bypass, everybody in the room stops. And we're at a teaching hospital, so I find this to be very valuable, especially as far as switching, because you're handing off, even though anesthesia and the surgeon has been dealing with this patient all day, you're essentially handing yourself off from controlling the patient and taking care of the patient on bypass to anesthesia managing that patient. Are you ventilating? Are the lungs expanding appropriately? Are the drips ready? Is the dosage agreed to? Has it been the same dose, or are you still figuring it out and going back and forth on what you're delivering to the patient? Are your vents off? If they're on, what are they at? And this is one big thing I tell for the students, and also even when I was a new grad and I first started working at Wisconsin, sometimes you just want to make everybody in the room happy. So it would be like, or the vents off, and the student will be like, yes, and turn the vent off. And I'm like, stop. Just because they're asking the question doesn't mean that the answer has to be yes. If something is happening or something is wrong, say it, share it. So if they're on, say something or say your concern. Is ISO off? Are the surgeon and anesthesia ready to come off bypass and they both individually respond? Is the perfusionist ready to come off bypass? Is the patient warm? And then there's some other ancillary ones depending on where you're cannulated. And I personally like to read the labs out loud. Sometimes anesthesia does it, but usually I always write it down on my glove. This is the potassium, this is the hematocrit, this is what our pH is, this is what the lactate is. I'm ready to come off, the patient is stable. And once again, that music is off, everyone is paying attention. Transitioning care in the middle of the procedure. So there's several different ways that you can do this, and I think it's just a personal preference. AMSECT has created I pass the clamp off, and it's very specific. You're not going to miss any piece of information for that patient. So one thing that you could do is potentially print out this list, laminate it, and have it in the operating room. And then list off every single thing, the patient, the name, their background, all of that. Or I think SBAR is a little bit more common. You're doing your situation, your background, your assessment, and your recommendation. What's going on right now? Why is the patient here today? What have I seen on bypass? What am I concerned about? Do I have any labs I'm waiting for? What would I suggest that you do? How should you treat this patient since I'm the one that's been working all day with this patient? And then also any events that have happened on pump that that you think are valuable, especially if your team does a post-procedure debrief before the patient leaves the room. Because if you're not the one in that room, someone still needs to say it. So make sure that you're concise and precise with your handoff method. So just some takeaways. The key to patient safety is communication. We've been drilling in all day. All of these errors, I shouldn't say all, most of these errors are happening because of communication issues. Communication starts prior to entering that OR, even in emergencies. Just be ready to go, be prepared, and be on the same page. If you have anything that you came in to the operating room carrying, leave it outside, check it in the hallway. You shouldn't be on pump thinking about personal things. You shouldn't be on pump using your phone, and that's something that's in the standards and guidelines. You should be avoiding distractions. And all of this has a reason. Your stress is going to be reduced with proper communication, and then you're not in that tunnel of distress, tunnel of distraction, and you're able to focus, which is what the patient needs and it's what the patient deserves. Treat every patient as if it's your family member, your loved one, someone that you care about. And maybe you're on your third case of the weekend, you're burnt out on call, but this is the patient's first time in this operating room, or even if it's not their first time in this operating room, this is a very high stress and high risk part of their life, and we need to show up for them every day. So just a little thinking piece for all of you guys kind of to end off with and think in your brain and take home. And potentially if you want to come up to the microphones and speak to it, that's also a possibility. How do you communicate in a stressful situation where speaking is discouraged, or if the team is not focused on your concern? Do you say something if you see something? How specific is your preoperative briefing, and do all of your surgeons commit the same level of detail to their briefing, or do they just copy and say, routine cabbage, routine cabbage, routine cabbage, you should know what to do because it's a routine cabbage? Have you noticed a difference in the team mental model and operative environment when utilizing initiation and termination checklists or timeouts, and then debriefs as well? Thank you.
All right, we're going to open up the floor for questions.